This is Sg2 Perspectives, a weekly conversation between the Sg2 intelligence team and industry thought leaders about the biggest trends in healthcare. We're happy you joined us today. Enjoy the episode. Big health systems have to prove that it's better to become part of a big system. Rural boards are going to evaluate it based on how many services did you keep in my local market. That's winning and losing to them.
Welcome to Sg2 Perspectives. I'm your host for today's episode, Jayme Zage. One of the important points of access for many Americans lies in rural hospitals, healthcare clinics, post-acute services in those small towns. And there are a lot of pressures pushing on these providers in the market today. It's been a while since my co-host for Sg2 Perspectives, Trevor DaRin, and I have covered rural health. We thought it'd be a good topic to do today. I've invited him here as my guest and share his perspective on rural health. Trevor, welcome to my episode today. And what is going on with the rural transformation? Is that what rural health is all about right now?
I don't like this. It's easier to be on the other side of the microphone. Rural health is not all about the rural transformation program, although every system that I talk with, big, small, rural, urban, metro, AMC, community hospital, has their finger on the pulse of how much money came to their state. Very few have grant programs open for applications and are getting the money out to grantees. My encouragement across the board, there's not that much to say about the program because all we've seen is the dollars that have gone to states and the areas of focus within those states, which mostly mirror the areas of focus for the program from CMS. We have to wait to see the specific grants that states roll out, how they administer those, distributing funding to rural hospitals and other entities that may not be hospitals. I'm encouraging all systems to stay close to anyone in their organization who's paying attention to someone's responsibility, who's focused on rural, people focused on responding to grants or disease-specific programs that overlap.
So more to come after things roll out. Why is rural strategy moving up the priority list for health systems?
Most projections show there's going to be more distressed hospitals in the next year than there is this year and 3 and 5 years down the road. That's not a functioning healthcare system if we have a lot of small rural hospitals closing. In an individual market level, patients are traveling further, worse outcomes. You're getting patients with conditions exacerbated globally, nationally. We also know that doesn't work from a systemic perspective. What's the future going to look like if the current funding model doesn't allow rural hospitals to be sustainable? There's questions about what the role big community hospitals and academics need to view as part of their mission to take across their markets to keep rural hospitals viable. That's not brand new. That's an approach systems have been thinking about for the last several years. The idea that we're not looking at rural hospitals to acquire them, but we need a program in a way to support rural hospitals. Maybe it's something as formal as affiliation and managed service agreements, having a menu of ways to partner that can make some of the really hard things for them to do, like billing, HR, IT, a more competitive talent pool in bigger cities. Big systems already have a lot of talent there, and many say, yeah, we have capacity. We can handle having a few other small hospitals buy in to those capabilities. Systems looking out across their market and saying, how can we try to keep these hospitals open is a reason that rural is always on the front burner. Capacity is the other one. We've seen more systems, especially those where their tertiary hub was close to capacity for academics dip back down below 100%. And we're seeing community hospitals pick up. It's not because overall utilization is going down. It's that community hospitals are picking that up. Distribution of capacity is happening within urban and suburban markets, but it's extending out into bigger geographies too. Even big academic systems have realized we're going to be able to backfill with higher margin generating cases if we can keep some of these medical admissions at a partner hospital. And sometimes it's easier to do that when the hospital is part of your system. Many have done that even faster than we anticipated. We've tracked this because now everyone has access to pretty good claims data, and we can see that transfers is a huge piece. Rural is about 20% of the total population. It's more than 50% of all transfers come from rural markets. And about half of those patients are traveling more than 50 miles. You're seeing this wide cast net of patients. You could say, well, great, that means we're serving this rural population, but those patients have almost 40% higher length of stay because they have to travel further back home. There's less post-acute care, rehab resources to get patients back to in small rural markets. If you don't have a rural specific transfer strategy, there's this huge portion of what's driving up your length of stay and challenging capacity that you could probably have a set of tailored rural solutions that's also going to make those rural communities and rural hospitals more sustainable.
You've alluded to the stresses rural providers, rural hospitals are dealing with. Aging population, chronic disease. We also know that because of that aging population, they're primarily Medicare in their payer mix. And what do we project? What else is distressing for the future of these distressed rural hospitals?
Workforce and volume are the two big pieces. Even when you're in critical access status, you're getting paid cost-based reimbursement, you still need a critical mass of patients to spread direct costs over. If you don't have enough services to generate enough volume, that's a huge piece of the equation. This was secondary research that happened several years ago, but in critical access hospital markets, a third of the patients stay local and get the service. A third of the patients leave because that service isn't available, and a third of the patients leave because they choose to go somewhere else. Guess who that third is? It's commercial patients with family support, it's patients with means to travel. That's a pretty scary third that's left for that local rural hospital. Expanding that piece of the puzzle, workforce is a huge part of that. And that's probably the place we've seen rural hospitals invest the most in the last few years is building local talent pipelines. When I started doing rural health research about 10 years ago, it was pie in the sky to think that a local rural hospital would build a pipeline for whether it's interns or education to the local high school. But at the same time, they had the old adage, if that physician comes here and they're not from here, they're not going to stay here. Building a talent pipeline that starts in high school has kind of become table stakes now. And there's also been a huge growth of rural residency programs where if the provider didn't grow up here, well, then we need to at least train them in a rural market. So they're either going to stay here or somewhere else. Rural understand those specific challenges. And hopefully they're choosing a rural residency program because they know and understand what it's like to live in those communities and that lifestyle.
One of the other topics you mentioned as you were giving your perspective on the strategies they need to involve around rural health has to do with whether or not they acquire those rural hospitals. But I'd like to flip that question. I actually grew up in rural Nebraska, and I've got one of the remaining independent hospitals in the state in the community I grew up in. Is that something you see a lot more rural hospitals grappling with? Is it becoming more important to be independent or to be part of a bigger system?
Big health systems have to prove that it's better to become part of a big system. Rural boards are going to evaluate it based on how many services did you keep in my local market. That's winning and losing to them. We also know that the way a big health system evaluates it's going to be totally different. There's two parts. There's how do we find the right patients that should stay local? Most rural hospitals don't have great analytics to track who those patients are and setting specific goals around how to keep and target which patients are better candidates to stay local and where those patients are going and reach out to those partners and try to build those pipelines. So that's a huge benefit health system partners can have in a way to bring a different value proposition to a rural hospital. You're going to be more viable if we can keep more of these general surgery and orthopedics patients local. And we have the data to show you where they're going today. And we have better infrastructure and business development, physician liaisons to help you do that. That's a reasonable value proposition. That's not the way I've heard conversations teed up. It's generally a fear of, are you just going to turn us into the video conferencing hospital where there's no physicians here locally and all we get to do is telehealth? That's the fear of small, independent local boards. It's important that we share more positive stories about health systems that do a great job there and do have a vision for how to balance access to care in rural markets and keeping patients local as much as possible.
You mentioned the telehealth aspect. That is a big part of connecting, whether you're a rural hospital, part of a health system, or you're connecting to an alliance of hospitals, those referral networks. Specialist care is more accessible through telemedicine in rural America. Are we making progress on using it more?
Rural hospitals have done a good job realizing telehealth for them was never going to be just about patient to physician visits. It was going to be about connecting to expertise, other hospitals, making access easier for patients, and probably that means leveraging a bigger partner. We went from fear, skepticism, uncertainty, hoping this was going to be kind of the workforce offset to things like ICU, behavioral health access. Every rural hospital has it. They have a partner. They have options. There's processes in place, and I don't hear complaints and problems in those areas. I hear that they're working great. MUSC had a market where they had to consolidate two hospitals. So they have two critical access hospitals. And they decided we're actually not going to renovate those. We're going to build a new one. And it's going to be a vision of how we leverage MUSC as this great internal legacy of telehealth programs. How would we build the ideal virtually enabled hospital that leans on every aspect of daily operations to make this hospital as viable as possible? The old model, they had tons of workforce problems, couldn't recruit normal rural challenges. They had the opportunity to build this from the ground up and how to do it best. And were able to both lean on internal IT expertise. They got a grant so that they can have someone that's focused on telehealth IT in person. But they built a hybrid staffing model from the start with a huge lean in and lots of training around how you were going to be a telehealth-enabled workforce right from the start. A lot of it is APP in person, physician virtual, but this is not about patient to provider virtual consults. It's really about enabling the local staff through telemedicine. That's kind of an easy concept, but what it enabled them to do is the CEO talked about, well, we have less fires to put out. Our workforce is actually really stable and regular because we're so backed up and supported. We knew it was always going to be a hybrid model. And so that allows me as a leader to be more in the community, think about growth, think about new services. They have higher inpatient volume because they can keep more patients local, which meant they had more outpatient subspecialty follow-up visits virtually, but it's leveraging internet infrastructure they put in place when they built the hospital. They knew they were going to have to be able to do that. And that's led to more on-site outpatient procedures. And within MUSC's network, they talk about this hospital as having one of the most stable workforces, having high quality scores, and stable financial performance. That's almost never what you think about when you think about a small, rebuilt rural hospital. That gives me hope that in every case, you're not going to be able to build new. But thinking about a hybrid virtual in-person workforce from the start, not thinking telehealth is just about virtual visits between patients and specialists. There's a model out there that works, and that makes me pretty excited.
You talk about that example of MUSC. If you were tasked with crafting a rural strategy for a health system, what would that strategy be?
When I get to work with rural hospitals, I always start with the same place. Use Vizient's clinical database to do volume quality relationship analyses. We found that for a set of outpatient procedures, there wasn't a difference in outcomes, whether the procedure took place in a small rural hospital or anywhere else. That's pretty exciting. Fun to be able to say that nationally. It matters a lot more to hospitals what the difference in quality is locally between their hospitals. Imagine starting a partnership discussion with a small rural hospital, and it's not how are you going to funnel more high-end surgeries that you can't do here to my tertiary hub. It's, hey, we identified 40 surgical cases last year that left your market that could have stayed. Here's how we can help those patients stay local and better support you, support your providers as they're doing visits, and support them in recovery after the procedure. That's pretty powerful and totally different. Those are life-sustaining procedures for those hospitals. The second piece is around balance between community need versus hospital need. We've seen that telehospitalists are not as prevalent, but we have a lot of great case studies there too. Virtual nursing have huge benefit to the day-to-day operations of the hospital, way more stability for the workforce, more straightforward to support than what often gets extended from bigger systems, which are like chronic disease specific programs. We have this program, we can push it out into the community, but those become one-offs and they're ultimately beneficial for those members of the community that you're connecting with. It's a community need, not a hospital need. Many rural hospitals are in tough shape. We may have to prioritize hospital need over community need when we're thinking about reaching out in virtual programs that are going to make the most sense to our local partners. Make sure you can extend access to new and emerging therapeutics into these markets, something like COPD, but you need a consult with pulmonologists to get to this new drug that's probably not available in a rural market. We could have down the road, 3 to 5 years from now, this huge disparity between rural and non-rural outcomes because this new therapeutic is really promising. Most systems would be pretty happy to have a pharma-specific outreach strategy that extends there regionally. The third piece is cancer and neuro, a place where a lot of that care isn't going to stay local in rural markets, but that doesn't mean every program's the same. It's great to have someone to consult with during the most acute intervention, intense moment of analyzing that stroke patient, but stabilizing them, managing them in the community, doing rehab, helping them transition to home. Those are all pieces that rural hospitals can also use, support, and help. Imagine being that rural patient not having to travel. Transfer data was 50 miles. We know outcomes are better when patients are close to home, and that's volume that wouldn't have been able to stay in that market locally. And at the same time, you're probably building a funnel for the higher end procedural cases too. That's how I would try to segment my rural strategy, not only keeping patients local, but building local capacity and earning patients coming to my hub down the road.
Sounds like a great place to start and a good place for us to end our episode. Thank you, Trevor, for sharing your latest thoughts on rural health strategies. And thank you to our Sg2 Perspective listeners. Until next time.
Thanks for listening to this episode of Sg2 Perspectives. Please don't hesitate to reach out to Sg2 if you have questions or suggestions for future episodes.